speaker is Dr. Todd Wilson, and Dr. Wilson will present EndoQuest.
Thanks, Fred. Thanks for the opportunity, SRS, for the wonderful opportunity to talk about EndoQuest robotics. Surgery is naturally progressing from open to multi-port surgery, and more therapy is being done completely scar-free. And some of that's being done right now with conventional endoscopes where we're doing endoluminal therapy. And it really is doing surgery. We're dissecting, we're cutting, we're achieving hemostasis, and it really does make a difference for patients. It's hard on the platform that we have because you're essentially using one arm. It's going to be really hard to convince a surgeon to use one hand to do a surgery, and that's what we're doing endoluminally. We've got some good tools to use with it, but the overall result is it's really hard to do. The endoscopic submucosal dissection is a procedure where we surgically remove a lesion from the GI tract. This is important for lesions that are larger because you don't want that to come back and you want a cure. But it's extremely hard to do. In fact, it's arguably the hardest procedure there is to learn. This is a study from a US learning curve of a single individual. And in his first 50 cases, the in-block resection rate was 74%, 76%. That means that he got it out in one piece 76% of the time. And when you look at negative margins, it was 45%. When you compare that to other studies, they're all consistent. And what it says is that it takes about 250 or more cases to gain proficiency. This is the longest learning curve of any procedure there is in medicine. And it's something that we need to improve. Okay. And that's what we did at EndoQuest. We tried to figure out what is it that we really need in order to make a difference. 2 hands obviously is better than 1. Triangulation of vision. And we created a platform that's going to be the platform of the future. This platform is modular, so you can put on instruments and endodrives that are going to be able to help you achieve scar-free surgery. We can reach the cecum and operate on the cecum and the duodenum, the stomach and the esophagus. And the difference is profound. On the left, this is what a conventional ESD looks like. This is one of the biggest and best experts in the United States doing as good an ESD as anybody can do. This is one of his educational films. And on the right, this is me doing a ESD of equivalent size, 35 centimeters in an animal. The first thing you'll notice is there's a complete difference in stability. You can see better. With the conventional technique, your scope is literally attached to your tool. I think one of the early adoption reasons for the intuitive device was that you really had stability of the camera. You didn't have to rely on the learning curve of somebody holding your scope. And it allows you to see. Vision is the most important thing when it comes to surgery. But having 2 hands maybe arguably is even more important. Tension and countertension is the key to good surgery. And when you see a good surgeon doing an operation, it looks smooth and easy, but when it comes down to it, he's doing as much or she's doing as much with their left hand as they are with their right hand. Bimanual operation leads to precision, it leads to accuracy, and that ultimately leads to better results, better in-block resection rates, better complications. And if you look here, there's a pretty big difference just in the speed and dexterity. I'm going to finish my resection of the same size lesion in 6 minutes. The guy who's gone through the learning curve and doing it as good as it can be, it's going to take him about 50 minutes. On the right, I'm picking up a suture off of the shelf and I'm closing that tissue. It is important to be able to close. If we can't handle our own complications during a case, then we can't move the needle in making endoluminal surgery a reality. We have to be able to handle those complications without converting to open or laparoscopic surgery if we want to make a real impact. We have study after study that shows that we can do this. We can close with surgical precision, with higher burst pressures than any endoluminal closure technique that there is today. That's going to enable us to not only really excel in current therapeutic endoscopy, but to take it to the next level. Now, that time difference, that's experts. But what does it mean for a novice? Well, it should be easier to learn. This is a randomized control trial. It was published in Gut, and this is comparing people who have EGD experience, but they don't have any ESD experience. You put them on a robot and you put them on a conventional, and the difference is dramatic. They're 2.5 times faster when they do it robotically. The in-block resection rate is 100% on the robot and 40%, kind of similar to that first study, in the conventional group. And when you ask these users, how would you do an ESD if you had a choice? It's 100%. I'd use a robot. We expanded that to our procedure development center over in Strasbourg in ERCAD, where we had dozens of professors come through and surgeons and gastroenterologists, and we had them operate. We had experts with over 500 cases doing large lesions greater than 5 centimeters. We had novices doing the same thing, both robotically and conventionally. We could get a novice at the level of proficiency and safety in 5 cases. Not 250, not 400, 5 cases. This is a game changer. So we wanted to do this in humans. We developed the paradigm trial, the prospective assessment of a robotic-assisted device in gastrointestinal medicine, where we focused on that hardest case that there is, the ESD. We did it in both surgeons and gastroenterologists, and we did it across a number of sites. We had great partners, colorectal surgeons, gastroenterologists, Advent Health, HCA, Mayo, Cleveland Clinic, and a lot of support in doing this. And when you get a lot of really good people who are helping you, they don't want to do the easy stuff. So they made my life hard. They wanted to go for the big lesions, and we did lesions up to 6 centimeters, and we did lesions to the descending colon and in the anal canal and around big curves. We had fibrosis in 45% of our lesions. So those are advanced lesions that have had either prior manipulation or there's further disease within that. The goal was benign, but when you're dealing with lesions like this, there's a pretty high probability that you're going to encounter cancer at some point. We finished that study. Our hypothesis was that we were going to make a difference, and I think you'll agree that we did. Our in-block resection rate was 100%. 100%, not 74% or 76% that we saw in those earlier studies. This made a difference. And the more interesting thing is most of those lesions were done by doctors who have never done ESD before. Our zero resection rate of 96%, unparalleled. This means that if you're a new user doing ESD, you're going to operate at the very highest level of expertise. And when you look at the most important thing as a surgeon, we had no device-related complications. This is a game changer. It works in humans, it works on the bench, and when you look at the complexity of these, it works for tough cases. I appreciate the opportunity to announce these results. We plan on really making a difference. Thank you very much.